So great to be here with the audience for Hackmed. I'm going to speak a little bit in Portuguese only first. Muito obrigado por todos que estão aqui na transmissão do Hackmed. Nós vamos agora começar uma sessão internacional com o Nigam e com a Marcia. So shifting to English now, that is going to be the language of this session. We are having an excessive amount of fun later before the session to start. We have really bright people to continue this session. Just take a look on their curriculum. So Marcia is the Endlot Professor of Demography, and she's the Chair of Global Health and Population at the Harvard THN. It's called Public Health. She is carioca. She's from Rio. She did statistics at Universidade Estadual do Rio. Then she did her master's or mestrado in demography at the University Federal de Minas Gerais. Her PhD at Princeton, and she never stopped. And now she's the chair of Global Health and Population at Harvard. And we are really ecstatic to have her. Her research is just so cool. She does research on urbanization and health and the effects of expansion of a Brazilian Amazon forest and the identification of social, biological, environmental risks associated with vector-borne diseases in the tropics. So, I mean, it's just the insane curriculum. Nigam is our Associate Professor of Medicine in Biomedical Informatics here at Stanford. He is the Director of our Center for Biomedical Informatics Research. He did his medical school in Baroda Medical College in India. He had a PhD from Penn State, and he did his postdoc at Stanford. His research focused mostly on machine learning to enable use cases for the health system and develop prediction models. Informally, I know Nigam since our course together in a program called Stanford Medical Leadership Academy, and he would be the one guy that we would be kind of just waiting for him to talk to see what is going to come up this time, because he's just absolutely bright. So again, thank you both for being here. My name is Robson Capasso. I'm the Chief of Sleep Surgery here at Stanford. I'm an advisor to our health innovation program that's called Biodesign. I'm an advisor on Hackmed. So thank you again for being here. Marcia, I want to start with you for a question here. We are seeing that right now we are having this COVID, and we were joking before that we do not have any idea, or we have very little data of how to move forward. What are the best policies? What are the best evidence-based policies that we can implement, the measures that we can do? So I want to hear your thoughts about what would be your data-based strategy that should be adopted in Brazil and other developing countries to face the current crisis? What are your thoughts in there? What are you thinking based on your experience?
Okay, so first of all, good afternoon, everybody. It's really a pleasure to be here. Thanks so much, Robson, for a very nice introduction. So what is really unique about what's going on in Brazil now is that Brazil actually has a lot of data. I mean, if you compare across countries, and it doesn't have to be just developing countries, if you even compare with developed countries, Brazil has a unique setting of information systems. It has a lot of data freely available online, and it has the transparency law that if what is available is not enough, you can request and you have access to it. But what's going on in the middle of the pandemic is that the data was kept secret. There were some issues at the ministry level in choosing the system to store the data. The system didn't support all the volume of data that was coming. And in the middle of a pandemic, truly, people don't have time enough to be able to fill out the forms. On top of that, some people don't really recognize why it is important to fill that complicated form that the ministry asks them to do. And the reason is, although Brazil collects a lot of data, it does not really use the data that it collects as it should and as it could. And what we see are really great experiences locally, like some cities that do use the data to make decisions, to monitor diseases, but others don't. Others just think this is some routine, boring work that I have to do, and the data is never looked back and used to make a decision. So I think that in the middle of a pandemic, we lost the understanding of how important the data really were, combined with, unfortunately, a leadership that doesn't really trust too much on science. So then if you have this kind of scenario, data are not important because you don't need it. You know exactly what you should be doing. So I think that on the one hand, we have a country with a unique setting to use the data the best way possible. On the other hand, we have a current situation where all the efforts done in the past decades to put together those databases are put aside, and we see what we're seeing now. We're in the middle of a pandemic where data should be driving our decisions, and we're seeing this right now that you have to make a decision on how to reopen cities. And then if you look at those proposals, it just drives you insane because it's not really being driven by data. So Brazil has the potential, but it's not really fully exercising it.
So Marcia, let me follow up on that just a little bit. So Marcia is now the Minister of Health, as perhaps it should. And then what kinds of data would you be looking at? Brazil is maybe not testing enough. So are you going to be using case fatality ratios? You're going to be using number of cases. What kind of data do you think it would be important now to make evidence-based decisions? And let's say, you know what, São Paulo should open 10% of the restaurants or 10% of the spots in restaurants and monitor closely. We should open the subway from this time to that time. So we can slowly implement opening measures instead of, it seems to me that Brazil is in a lockdown that people perceive to be intense, but not really is that intense as it is perceived by lack of communication by leadership. Just your thoughts a bit. Listen, those are important metrics, and that would be perhaps my strategy to start thinking about this.
So I think that if we could start again and do the right thing, first of all, I would use the entire network of healthcare that Brazil has, and particularly the network of primary care that is all community-based, that is completely neglected in the response to COVID. So if you use the family health teams in a way that, one, they get training, two, they get all the protective equipment, those are the eyes of the policymakers on the ground. They can do active case, find people that have the comorbidities, that the elderly. They can help with promoting isolation of individuals that cannot leave their house. They cannot promote isolation. They live in communities or slum type areas. And they can also do contact tracing, which Brazil is not doing. So if we have the support of primary care from the beginning, just with that, we would have better numerators and denominators. The problem now is we have a problem both in the numerator and the denominator. So it doesn't matter which data you get, it's underreported, it doesn't show everything, it's delayed because it takes some time until it's reported. So the very first thing I think it had to be done, and I think we still have time to do this, is to bring the community health agents on board. That would make sure you have better data. The second thing is there's so many researchers trying to help. And we have one very nice way of accounting for the fact that information is reported with a delay. So I have the symptoms today, it's only going to get reported 2 weeks afterwards, 1 week afterwards. We can correct for this. So every single day, we can just take the data that came in, correct, you already have better numerators right there. And if you had the testing, you also have better denominators. So the problem is, the stage we are right now, we didn't do anything of that. We're not using the health agents, we're not correcting for the delay, and we're not doing contact tracing, nothing like this. So what we could do now, well, it does require a massive effort of coordination with all the municipal and state health secretariats to try to get the best data possible and to improve surveillance. So my point is, if you try to reopen any city now without having implemented a surveillance mechanism, and the surveillance is not to track deaths, that's too late. It's not to track when they are hospitalized, that's also too late. You have to track symptoms. The symptoms happen, you have to be able to test that person and all the contacts of that person. So I cannot see how Any city can talk about reopening if you don't have a very good surveillance in place that is trying to detect people when they have the first symptoms. You have to monitor the hospital to guarantee that you're not at capacity. I'm not saying you shouldn't use that because you don't want your hospitals to be overloaded, but you have to be tracking symptoms and you have to do the contact tracing. So with what we have right now, without change, we just can't do it the right way. We need to do something else to be able to do it the right way.
That's fantastic. I think this just shows how actually the coordination, the let's say the healthcare professionals these days are a small part of the equation. You really are, while there's a significant focus on hospitals and clinics, but the response to this requires coordination about infrastructure. It requires coordination about multiple branches. In this sense, it needs to be perhaps government. It's hard to put this burden on the private sector. Who can coordinate this many actors? How that would be, and that's a lesson. But I want to ask Nigam, for example, perhaps on the context of the healthcare system focus, a hospital and clinics. And first, just a little background. Nigam is the guy that every Wednesday, when we have the update in Stanford Medicine, we want to hear his opinion. He's the one that uses numbers to predict the number of beds we're going to need, the number of ventilators we are going to need based on other data. So looking at that and looking at this context that Marcia just said, Nigam, what do you think that healthcare networks in Brazil, hospital chains, doctors, what kind of, let's say, predicting models, or what kind of predicting tools they should be looking at least to have an idea about the resources they're going to need within the healthcare system?
Mm-hmm. Yeah, so there's a couple of ways to think about this issue. On the health system side, you don't need fancy predictions. What you need rather is a clear articulation of your policy. Like, what is it that you're optimizing for? So for example, if the goal is to prevent overwhelming the healthcare system, you can monitor your hospitalization rates with a simple moving average of the past 3-4 days or something. And based on that, calculate the threshold at which, under a range of plausible scenarios, you will run out of bed capacity. And if you cross that threshold, then you dial up your containment measures, such as sheltering in place or whatever is at your disposal. So that's the health systems. Think of it as a fire alarm, as in relatively trivial to set up that fire alarm. The harder part is to say, are we moving towards the fire alarm boundary or away from it? And if you run the numbers, randomized testing becomes too expensive. And so you have to combine with symptoms, as Marcia was saying, and come up with a dual or even 3-tiered testing strategy, whereby testing a small group of humans, you can get an accurate estimate of the percentage of active infections in the community and whether it's going up or coming down. Because if you're closer to the threshold, but your active infections are going down, it's okay. You don't need to sound the fire alarm. But if you're close to the threshold and your active infections are going up, well, you're going to get hosed in 2 weeks. And so that requires some coordination between the people running the health system and the public health officials. And without that coordination, it's really hard to have any kind of coherent decision making.
That's excellent. That is excellent. And I think we were talking a bit before, but I think there is quite a bit of focus on what are the key technologies that would be helpful at this time. So everybody's looking towards virtual care tools, telemedicine tools. What are some other sensors that could be used in people for earlier detection of algorithms, since we may not have in the future, let's say, tests for everybody until the foreseeable future in place like Brazil. So people like Eric Topol keep advocating for, hey, listen, everybody, a lot of people are using Fitbits and other wearables. Perhaps not in Brazil as much, in the United States is more of a reality. But my question is for you, Nigam, what would be technologies that healthcare professionals and people that are working with this should be thinking about or working more towards early detection and surveillance and kind of tool that would help taking actionable items in here? Actionable.
So again, I'll go back to this notion of what's your goal clause, as in, if both of us, we sit in the Stanford healthcare system. One of our goals is to make sure that our patients get taken care of, and for that there'll be a set of technologies that we would look at, remote monitoring, telemedicine, what have you. But if the goal is to make sure that enough economic activity happens, that people have food to eat, then I would not be looking at telemedicine. I would be looking at things like smart thermometers, symptom surveys based on SMS text messaging, and then trying to anticipate the region where I need to go do a biological test to get a handle on the spread of the virus. And so the technology we would use would depend on what the goal is. And what happens typically, especially in kind of a capitalistic system as the US, is that most healthcare systems, even though they're incorporated as nonprofits, I jokingly call them not just for profit. I mean, it's unclear who is their primary constituent. And it's hard to answer what technology. So in broad strokes, if you define the goal being estimate burden of the disease, then I would look at technologies such as symptom surveys. Fitbit is just a expensive way for symptom surveys. It costs $100 as opposed to a text message that costs you $0.01.
Excellent.
But it's a symptom survey. And you're looking at temperature.
We should be technology agnostic and focus on the need.
So you have to figure out the what. Yeah, you have to figure out the what, and then figure out that given your local circumstance, what is the cheapest way to do it, as in the how. So smart rings and Fitbits and Apple Watches are fine for people who make $200,000 a year, no problem. Like, please go ahead and do that. But if you're trying to survive on $3 a day, I mean, come on, you're not going to buy a Fitbit just to be monitored. An SMS, which is free, is probably way more effective, even if maybe slightly less efficacious.
Gotcha. That is excellent. That's excellent. And Marcia, you that are familiar with the Brazilian healthcare system, that is quite unique. It is one of the things that sometimes we have a problem explaining to our counterparts here in the United States. It's actually anywhere in the world. Listen, there is a single payer for healthcare in Brazil. There is a primary provider. It's a universal healthcare system in Brazil, but not really. I mean, that is used for most of the population, but it's used, then there is a good number of people that want to use a private sector. On this context, one of the questions that comes all the time is, listen, how do you think, is there a way, or is ethically even, is it possible to separate the role of the private sector and the public sector? I mean, let's give you a concrete example. I do have the Hospital da USP. USP Hospital has all the ICU beds full, and maybe Albert Einstein doesn't. So if persons get sick in Paraisópolis, that is a slum in Brazil again, what should happen on this? Should the government contract with hospital? I mean, I think, of course, I'm trying to oversimplify a deeply complex question. But what is your view on that situation, Marcia? What do you think it should be now? Again, you are the Minister of Health. I'm campaigning for that already. So if you are there making those decisions and trying to make those decisions, you will need to design the perfect healthcare system for Brazil right now on the next 5 minutes that I'm giving to you. How would you face that situation?
Yeah, that's a very easy question, huh?
Thank you.
So here's the thing. So we saw, we have a few proposals that were put on the table. So there is a group, and I wrote a paper simulating this as well, basically saying we should put all hospital beds together and they become part of one pool, and whoever comes gets the beds. And Spain did that. in other countries that had a collapse of the hospital system, that's what they did. There is no public-private. We have hospital beds, period. Let's use them. Now, what happened in some cities in Brazil is that SUS paid a better rate and contracted the private beds. And this is, you know, if you're in the middle of a pandemic and people literally can die because there's no beds and there's an open bed, I think there should be a discussion of ethics. And honestly, since SUS was created, there's this promiscuous health system that you have the public and private, and it started that way. And the public side has always been underfunded, always, since the beginning, was never fully implemented. And since 2018, it's about $5 billion that were not put into the health system because of the austerity measure. So here comes the pandemic. The system is already underfunded. So I think that if you are in an extreme situation like this, that none of us have ever seen in our lives, that's probably the time that, no, I'm not going to pay more. I don't have that much money. We need those beds because people are dying. But it's not an easy thing to do, because it would require the private sector to be willing to give up their bed, knowing that somebody could come with a lot of money and say, what, you gave this bed to somebody from SUS? So I don't think the Brazilian society is ready for this. I mean, we've been an unequal society probably since you know, the ships from Portugal arrived.
Yes.
So we're not ready for this, and it didn't happen. It didn't happen. What we saw was SUS paying more for those beds, and I can't imagine any city being able to implement this. What we saw, for example, in Rio, there's a private hospital and a few of the private insurance that put money for one of the can't-pay hospitals. They did that. And honestly, I think they should be doing more. They make a lot of money, right? So again, this is an extreme situation. It's not something you do every time, but in the middle of a pandemic, and considering how, if you look at the mortality indicators due to COVID, all the inequalities in Brazil are right there. You don't even need a legend. It's right there. So it is an extreme moment, but it didn't happen.
Yep. But that's the reality. And again, thinking about that scenario, we do have data. Data is not being implemented. Science is being doubted. Policies are not clear. There is this discrepancy. There's this disparity moving forward. That is something that we really, I think, need to really come to terms and start making some deep discussions about this. And it's complicated. The moment right now may not be the most favorable for that, I believe. So it's good that this audience and everybody being aware of that moving forward. That said, let's try to get a bit more less bland over here and moving into a more, one of the things we are seeing, and I think what we are discussing here is how healthcare these days is so intertwined with so many other disciplines. So the traditional doctor that I was educated to be growing up when I did my medical school back then, I think the skills, the knowledge, the method of what is taught. So what I'm talking here, I'm talking to a statistician who is the chair of global health, and she brings all this valuable information to me. I'm talking to someone who is a computer science person on top of being a doctor over here. So what is your view? I'm going to start with Nigam, and then I want to hear Marcia as well. But what is your view? Listen, if I am moving forward and I am advising a school of medicine and in a healthcare system broadly, if you will, because, and I'm going to explore that one. What healthcare professionals, let's broaden this more than just doctors. What healthcare professionals need to know moving forward? What are the topics in school? Listen, you may not need to know as much anatomy as you learned before, or when you are studying for the admission test to get into a medical school, you may not need to know as much chemistry, but you need to know more statistics. So what are the skills do you think that people need, and what should be implemented in the medical school and healthcare professionals moving forward? Nigam, your thoughts there.
All right. So the one phrase under which I park the things needed to know is under data literacy. And you can, as a clinician, you can break down the kind of data literacy into two buckets. And I jokingly refer to them as the equation of medicine. So you can imagine a simple equation for those of you listening live, take a piece of paper and try to write it down. If risk is greater than some threshold, then take action or do X. That's essentially the gist of medical decision making. Now, what happens is that when a patient shows up, a clinician goes through 20, maybe 15 of these in their head instantaneously, reconciles all of the risks, and chooses one or two or a minimum set of actions to take. And the medical training is essentially learning this neural net in your head to estimate these risks accurately and then take the right action. Now, what happens the majority of the time is that the risk estimation from a computer science or a statistics standpoint is either a classification problem or a prediction problem. And whether it is above a certain threshold or not is roughly relevant, like understanding probabilities. And the threshold, unfortunately, is never clearly defined. Even in something simple like the ASCVD risk equation that a lot of you might be familiar with, you get a number which gives you the 10-year probability of a cardiovascular event. And if it's above 7.5, you're supposed to have a conversation with the patient and give them a statin or something, or get them to exercise or eat less or what have you. So that's a very cartoonish example. And connecting it back to the current situation, on the risk stratification side, we would need to understand the probability of exposure versus the probability of getting complications if exposed. So imagine a little grid, XY axis, where on one axis is probability of exposure, the other axis is probability of getting complications. So if you have somebody you're trying to treat that has high probability of being exposed, which in the US we call them essential workers, and someone who has a high probability of getting complications based on just their age, gender, and the age, sex, and having comorbidities, you have to do something different. So this is a very simple, intuitive example of having data literacy so that you can do accurate risk stratification. That is absolutely a crucial skill because risk stratification tells you whether you should act. And as more information is thrown at you, the majority of the job is going to be saying no. Saying, okay, I saw the numbers, I'm not going to take action. Because if we keep reacting to every damn number thrown at us, we're just going to have incidental findings and just unnecessary overtreatment.
And so, that is so counterintuitive for doctors. That is so counterintuitive for doctors, because doctors do want to take action in any little thing you see that is wrong. You want to do something about it. And that is, I mean, as time goes, you end up doing by experience because you do your own mistakes and you learn from mistakes from others, that sometimes doing more is actually worse. So the whole do no harm. But to the point is, yes, we learn this by experience, but we should not need to learn this by experience. We should know that by analyzing the current set of data, we should not take action. That's fantastic.
Exactly.
That's awesome.
So data literacy, so that you can do risk stratification and use it to choose when not to act, is the most important skill you can learn as medical professionals these days. Because there will be more data thrown at you, genome, metabolome, proteome, whatever, right?
Yeah.
Don't act on everything.
That's fantastic. That is so true. That is something that we learned, and again, it's transparent these days as well. And one other thing that is kind of controversial, I mean, I'm not going to ask a data scientist, that's in case both of you, to tell me more of even. So yeah, it is obvious. But one thing that it triggers me in Brazil that I think we need to think harder about it, the need for more multidisciplinary work in healthcare settings. So the doctors being, let's say, the last decision makers of everything, I think this routine needs, I know I'm gonna be beaten up by my friends who are doctors, but I think every time more that the shared decision making needs to be done with a team. And I think in order to improve access to healthcare, more and more treatments and things that have reduced access. So we have a lot of treatments that are basically risk-free or very little risk. I'm going to give my example. I treat this thing called sleep apnea. The main therapy option is something called CPAP. I never heard of anyone dying by using a CPAP. It is, but the number of it may take a year or two for someone to see a doctor, get a sleep test, get a CPAP machine to a therapy that is risk-free. And in medicine, we have plenty of examples that are similar, that potentially a respiratory therapist could see this patient, or for a hearing aid, an audiologist could be seeing these patients. So we don't necessarily need to be seen by a doctor for everything. So working in multidisciplinary teams to improve access and having those teams coordinating. Marcia, I don't know if you have any thoughts on that.
Yeah, I do. And not being a physician,
I'm pretty sure you want a statistician on the team.
Of course, always. So I couldn't agree more with the data literacy. And I would start the data literacy even a step back, which is they have to understand why data are so important to make decisions. Because a lot of people don't. A lot of people think that, you know, being in a hospital, in a health unit, collecting data, that's boring, that takes time. Why am I going to fill in this form? That's the very basic fundamental thing before even they use that for risk assessment. I think that any healthcare professional needs to understand social sciences, because, you know, there is an entire context around where the patient is. And if you don't care to know about that, you may not understand what is causing the disease. You may not understand why the drug you prescribe is not working. The context is as important as just your physical examination. So social sciences is critical to understand who that person is and to understand where they live. And honestly, that's exactly what community health agents in the primary care in Brazil do. They go at the the person's house, so they go way beyond just the, you know, the healthcare unit. So social science is critical. The other thing is, and this is not just for healthcare professionals, this is for all of us, we need to do a much better job in understanding how to communicate. You know, the time that we just wrote papers and made a career out of it is gone. We gotta put ourselves out there, engage with the public. And the truth is, a lot of the scholars don't know how to do that. So we gotta train the healthcare professionals to do this. And a last thing I would say is, and this is a gap in most of the universities that train healthcare professionals, but I think everybody getting any of the different careers in healthcare, you should spend at least 6 months in the field learning how to listen to people, because they know their problems better than anybody, learning how hard it is to actually solve problems on the ground. So I think that changes a person as a human being, but also as a professional that is going to be dealing with health. So
let me clarify that, because this is good, kind of again translating into Portuguese but still speaking in English, with exactly what you're saying. Would you say, for example, that doctors and healthcare professionals, should they be let's say Brazil is one of the few countries that don't have a mandatory a year, let's say, community health service, right, that doctors who graduate in public university should spend a year working in there to have this hands-on, and perhaps increasing in our medical school curriculums. I think there are some medical schools in Brazil who have a more innovative curriculums, but some still don't. And so how to have more hands-on experience from day one in medical school, or nursing school, or other schools, if you will. Because I think, I mean, I'm going back to the same topic, but I think, as you're saying, community agents. Are the community agents doctors, Marcia?
They are. So there is a doctor in the team, in the family health team, but they
not
are
all doctors, right?
Not all of them. No, you have nurses, you have nurse technicians.
Correct.
No, they have some medical training, but
so perhaps these people have more hands-on activity, but perhaps the role of the nurse practitioners, the other members of the team, should be expanded. And perhaps, what do you think of that? Because I think that is a discussion, and it's so hard in Brazil to have with doctors, but it's important.
So I'm glad you asked that. So 2 comments about this. I'll start with the last one, which is expanding the role of nurses. I couldn't agree more. But the medical corporation in Brazil is very strong, and they are not really willing to give up some of the tasks that they perform for the nurses. That's the truth. But they should, because the nurses can do so much on the ground, and now they are limited because of legal issues. Now, the second thing I want to say is about the training. So Brazil actually has a mechanism in place, and it's not used. So a lot of people don't know anymore about the Rondon project, Projeto Rondon.
Yep.
It still exists. And a
Didn't know that.
lot of people say, what is that? They never heard of it. It's perfect. Honestly, if I had the power, what I would do is, if you go to a public university, you have to spend 6 months somewhere. But, you know, it's not like if you are, you know, in Rio, you're going to be doing community work in Leblon. Forget about that. You're going to go to the semi-arid, you're going to go to the Amazon, you're going to go to the Northeast, and you're going to spend 6 months there. It doesn't matter which kind of degree you're taking, which discipline, there's room for all of them. So Brazil has a mechanism. It was never fully used as it should.
Yep. And yep. That is fascinating, and that is fantastic, because another thing we think we have in Brazil, it's the selection process for doctors and healthcare professionals in Brazil, based only in a test, tends to pick up just a quite skewed portion of the population, perhaps offering more access to a various degree of people with all sorts of backgrounds and ethnicities and origins in Brazil. That would be key in order to improve especially public and population health in Brazil. I don't know, that is one of my impressions as well. Yeah,
and I think one of the mistakes that happened during the Lula government was the opening of so many medical schools. And, you know, we need quality, not quantity. And now we have those profusion of medical schools. People think they're getting a great degree, and they're not. And I don't think that's honest to people paying for those schools, and it's not good for the health system that is putting out there professionals that are not fully equipped to be able to treat anybody. That is a great point. And I'm going to change topics just a little bit, because this is a question I feel that people in Brazil will benefit quite a bit. It's another discussion that's not easy, but that's why you're here. That's why we picked you, both of you, to discuss this. So the situation is, there is a lot of discussion in what is so we tend here in Silicon Valley to think about a lot of our, what we call ecosystem. We tend to believe that we have a strong but transparent interaction between government, academia, industry, school these days, and we tend to believe that that's one of the reasons that foster innovation has been fostered here, and the same thing in New England, in a sense. But the number of tech companies here and startups and so on. But besides the buzzword, Nigam, I want you to explain to us what are some key lessons that a country like Brazil could understand. So just give you a little background. Brazil has a lot of institutions where the top institutions would be public teaching institutions. We have some of the private as well, but some are public. The interaction with the industry for development of solutions, if you will, it is still quite limited, and how to make this quite transparent but effective. So if you are, again, given the canvas to draw this, so Marcia, as the Minister of Health, hired you to say, you know what, I now need you to draw for me how the University of São Paulo is going to establish a relationship with the private hospitals, the private pharma companies, private medical device companies, and startups. What are the key first steps you think are necessary?
So the first step I would do is to walk over to the Ministry of Finance and the Department of Justice and ask about what are the bankruptcy laws in the country, and is it corporate liability versus individual liability? And I'm not joking. This is the exact question I would ask.
Hey, this is exactly it. Yeah.
Because same issue happens in India as well. Like, you have elite institutions like IITs, but the corporate law structure is such that if you innovate and you have a company and that goes bankrupt, you have personal liability. And I mean, that basically is the best way to kill any innovation. Yes. So you have to look at the reward structure. That, are you getting rewarded for risk taking, or are you getting punished for risk taking? And are you getting rewarded for good outcomes, or are you getting rewarded for trying? And the quadrant you want to be in is you're getting rewarded for risk taking and rewarded for trying. Most economies compensate risk-taking and good outcomes.
Correct.
And so unless you can change that, the Ministry of Health actually would have very little influence. I mean, the Ministry of Health can probably influence things like laws around patient privacy and data access, but that's just a small part of the game. The bigger part is access to capital markets and liability, and how are people rewarded for trying.
Excellent. That is excellent. And in the context of, let's say, you have a lab, a prolific lab at USP, that is the biggest, again, medical school. It's the AIMS of Brazil. And then you do have a bioinformatics lab, and then your students want you to advise them outside, or they want to use some product that they develop in your lab. They want to start a company out of that. So I know it is, for us, it's quite trivial. It's like what we do quite a bit. But what kind of tools would you say, listen, this needs to be transparent. This needs to be disclosed somewhere. People can see easily what each one is taking. But I think still this interaction between what has been done inside the university, how that translates to, let's say, startups. So what would you advise, Marcia, on that?
So, I mean, here, who are you asking?
Yeah.
No. How you would advise Marcia? Then I'm going to ask Marcia the same question. She's the Minister of Health.
Yeah, okay. So from an academic standpoint, I think the universities have to look at their founding charter and ask themselves, is their charter to train people, or is their charter to produce members that are useful to society? If you look at Stanford's founding mission, one of the things, and this is a very charged statement, is basically says, our goal is to produce graduates that are immediately useful to society. That is in our founding mission. And so in order to do that, the rest of the regulations that Robson and I are under, for example, we are allowed a certain number of days every quarter to engage in outside professional activities that accomplish that mission. So they're creating space on the books for us to spend a few hours every week in order to disseminate our professional knowledge outside. You have to couple that with transparency, saying you have to disclose everything you're doing, because if you allow stuff and keep it secret, I mean, that's another recipe for disaster. So from a health ministry standpoint, my recommendation would be to go to those medical colleges and allow their faculty to spend time outside, but under the equivalent of a Sunshine Act that says everything you do outside has to be publicly reported.
Yep. Marcia, knowing the Brazilian context and knowing very well the Harvard context and the academic sector here in the United States, what do you think are some key lessons learned here from the good things we made, but as well the mistakes we do and the things that need improvement here, if you will? How would you translate that? Because I mean, my perception, personal perception, is that we do, for lack of capital, for lack of human capital, if you will, but for lack of a clear guideline in how to proceed and to translate things from inside academia to outside, I think that, and besides the tips that Nigam just told us, like for rewarding more risk-taking behavior, but what are the key lessons you would say?
Yeah, so a couple of thoughts, and I don't know what is the legal mechanism in Brazil, Nigam, from what you mentioned in the beginning, so I don't know those answers, but first, a few thoughts. First, Brazil has some good examples actually that worked. So the Butantan Institute is one. Yep. It's public, it has a private area, it makes deals with industry, it produces vaccines, and it's all in there. And it also provides courses. So it's all in one institution. Fiocruz is another one, right? It produces medicine, it produces vaccines, it's all in there. And it's public, but it makes agreements with the industry as well. So we have some good examples, but those are big institutions. The key issue for me is, how do you make this work when you talk about academia, when you're talking about small groups of researchers making those deals with the industry and trying to help this with the government? I'm not quite sure how those things are really transparent in Brazil. I think another big problem in this is, First, it's not the Ministry of Health that oversees medical schools. It's the Ministry of Education. So we have to remember that in Brazil, it's kind of funny. So it's not the Ministry of Health that oversees education and health. That's one point. The other one is all the public universities in Brazil are receiving less and less funding. So it's becoming harder for researchers to do the innovations that they used to do. And to me, that's a problem in trying to make deals with the industry, because you become very vulnerable. The industry comes with the money, you don't have any money, and that worries me a lot. Just because of, again, about the culture, about, you know, and we have some bad examples as well when, you know, all kinds of crazy things happen. And this is not just in Brazil. We just had a recent case here at Harvard that the person ended up in jail, the professor ended up in jail. So my fear is if you are in an environment where you have a lack of resources, not a very clear pathway. I know it's extremely hard for people to start startups in Brazil. It's a bureaucracy. It's incredible. You almost give up. In this kind of a scenario, you become very vulnerable to deals with the industry that may not be the most healthy ones. And I think that on top of all the legal issues we may have, again, I don't know, but that becomes a problem. And, you know, I don't think that we have a good, well, let's put it this way. We have plenty of examples where transparency and ethics were not really the top for some of those industries seeking those deals. So I don't want to generalize this, but I think we have enough examples to be extremely careful. And if we had solid funding for the universities, we would be in a different position. And recently we had one example, the vaccine for Zika, right? What happened? It's being developed by NIH, that's a governmental institution. Then it gives to the industry, finish it. And the industry says, okay, I'll do it, but that's going to be the price of the vaccine. They say, no, you're for the developing countries, for the poor countries, you're going to give it, you know, at cost or no cost. And they were not willing to do it. All the development, all the intellectual development of the vaccine was done in a public environment. The private takes it and wants to charge. So that's another example. And I'm sorry to say, but we have plenty of horrible examples from the pharmaceutical industry. It's not that all of them are bad, but we have plenty of examples that are not good ones in this type of partnership. So
it seems to me from if I'm hearing correctly, I think it would be one, the one thing that I see is very clear guidelines in how to proceed with this. It seems like one would be excessive amount of bureaucracy would lead to a lot of room for misinterpretation, and the second would be transparency. So if someone wants to check, Marcia, what are the companies you are collaborating with, what are the companies you have shares with, and how many hours you're placing, if there is a, let's say, a website, a disclosure website that you could consult, one would be great. Second, perhaps, is Office of Technology Licensing inside the institution that can give you clear guides, and the university per se having some clear numbers. Listen, you can consult clear. So that is my perception in interacting with everybody in Brazil. I mean, how can you draw real guidelines, clear ones, benchmarking some institutions that were more or less successful from them, let's say Harvard, Stanford, and then adapting as time goes, because technologies change and numbers changes, and so I think I would say with those three things, if I'm kind of trying to paraphrase here what was said, I think for the audience those would be a good messages, I guess.
Yeah, and we have some of those mechanisms here in the US that you have to, every year you fill out conflict of interest, you have to report every company that gave money to you, and once you sign that document, that's your word, and there are audits once in a while, and you can end up in jail. Yes. And we don't have this in Brazil.
Yep, I think that is key. That is key. Talking about that just a little bit more, I mean, I keep going back and forth, but one of the things you just said that struck me now, and I need to ask, I think to me recently has been, it is almost like the amount of funding for science in Brazil got a downturn over the past couple of years. There was not consider, let's go this way. It seems to me for a company to be prepared, or a company, I'm so sorry, a country to be prepared for the future now, really, most of what we need to do is to do scientifically based guidelines, policies, decisions. And at the same time, Brazil must have divested our funding institutions that fund science. Marcia, can I pick your brain on that? I know I'm not throwing you easy questions.
Yeah, well, so that's exactly what's happening, right? I mean, again, if you look at the potential that Brazil has, so I'll tell you one company, Embraer, right?
Yeah.
We produce our own airplanes, for Pete's sake. It's all Brazilian technology. And then you just give it on a plate to Boeing, right? So
Yeah.
Brazil has an enormous potential. When Zika hit Brazil, the most relevant science was produced in Brazil. Who was the first paper that showed the causality of the virus on the brain? It was a group in Federal University in Rio. It was done in Brazil. So
excellent.
The Brazilian scientists and scientific institutions, they are ready to deliver. They're not, they're not behind anybody. They're as good as any other institution. They can do it. But I mean, you can't make miracles all the time. You need the support. You need the money to do it. And honestly, I cannot imagine how a country can develop without innovation, without science, produce locally. If there's one lesson among many that this pandemic is showing us, is that there is a price for a globalized world, which means when you need the masks, they're all done in China, and China is not going to send them to you. And you can't produce them in your country because you just decided that globalization was nice. So, so Brazil has the scientific expertise, that the quality is very good, but that, you look at the two main funding institutions from the government, CNPq and Capis, right? They're basically out of money. The funds are being cut. If you compare the amount of resources that were put for institutions to support projects when Zika hit the country, and now, you just want to sit down and cry. So, it's the potential is all in that. That's what makes this whole story so sad, is because the pieces are there, but the glue that connects them to make a brilliant story is just not coming.
That is the point. I mean, I think that moving forward, I think that scientific society, as you said, one of the things that I'm seeing, that again, in a positive note, what I'm seeing is even more and more scientists are becoming every time more savvy in how to communicate with people. You see a good amount of scientists in Brazil these days. Now, actually, the society in general are actually following them on social media. So some of them are quite social media savvy and know they're learning how to communicate. So I believe and I hope, especially the target audience that is looking here, it's actually getting to interact more, getting to think, getting to put more doubts on their minds, the certainties, if you will. But to listen more to those actors. So I do have hope with your point that increasing communication by scientists are going to show the importance of science, that is going to show the importance of evidence-based decision-making into this whole process. And again, moving forward, let's hope that this is the case.
Yeah.
So I want to ask you guys to see if you do have, I think we are about our time here, 1 hour. I think we can keep going here forever if you could. This is so much fun to talk to both of you. But Nigam, I wanted to hear perhaps your closing remarks moving forward. What do you expect? How do you expect we are going to get out of this moment in a broader term? I know it's a broader question, but I want your thoughts. How we as a global society, if you will, we are going to get out of this pandemic or this crisis or this moment we are living?
So, of course, it's a very broad question. The thing that is missing in most decision making is a quantification of, given your local circumstances, what is tolerable risk? Until we define tolerable risk, we don't know to what level we should titrate our efforts and what trade-offs we should set up between controlling cases, which is epidemic control, and destroying the economy in the process. There's no free lunch here. There's an inherent trade-off. You either control the epidemic, you save your healthcare system, and you save your economy, and you can't have all three. And so in order to decide where you situate yourself in this impossible trade-off, you have to have a notion of what is tolerable risk in that society, and what is the price you're willing to pay in order to control a case. I think in terms of, can we define that I'm willing to spend $1 to control a case or prevent a case? I'm willing to spend $10 to prevent a hospitalization. I mean, we need to get down to that level of clarity in our leadership so that then we can develop the policies and the frameworks around it and the messaging to get people on board. But without that, I mean, we're just flying blind and being very reactive.
That is powerful. That is sobering as well. Marcia, I want to hear your thoughts on like Nigam didn't leave the situation that easy for you.
Yeah, I remain optimist because otherwise I cannot do my job. So I think we still have time to change course. We need more voices. There is a lot of group of scientists trying to do the right thing. We need more. There's not a time to hide. It's the time to come up, to speak. For all of the students listening, you are the future. So speak up, carry the flag of science, change the world with this flag of science, because there's no other way. And honestly, I think we have to continue to show ways forward. So I've been talking about primary care and the community agents for a while now. I'm going to keep saying this. And there are a few cities in Brazil that are trying to incorporate them. So somebody is going to listen. So we need this. We need to showcase the good examples that are happening, right? And it's not just about talking about the bad things. So we need to showcase the good examples. And honestly, it's our duty to get the data, no problem, no matter how many problems they have, and put those results out there, expose the inequalities that are being reflected in those indicators. And really, we show the cost of the inaction that we're seeing. The cost is not just monetary. I'll let the economists deal with the economy, but I'm going to measure the costs in terms of lives and just put right there on the face of the leadership we have right now. That's what we can do. And I think little by little, by doing this, we're planting the seeds and some changes can happen. And all of the young folks listening here, you got to do the same, because if you just go with the flow that is happening right now, nothing is going to change. And above all, for those in the US and in Brazil, but here in the US this year, vote.
That is excellent. Marcia, Nigam, it was really quite an honor to pick the brain of both of you. I hope this Hackmed audience enjoyed this really as much as I did. I'm gonna hunt both of you guys down at some point to drink a beer or wine and kind of even gossip more. I cannot even see what can come up after a glass of wine with both of you. That would be quite fun. To the audience there, I think hope you picked up the message that this panel brought. That to me was quite clear. Is 1, learn data science. That is 1. 2, make evidence-based decisions. And 3, be vocal about the things that need to be done. Don't shy away of making decisions and showing up. So with that, I'm going to finish here. Thank you so much again for both of you for participating on this, okay?
Thank you.
Thank you.
Thank you.
Hello, Nigam, Marcia, Robson. Thank you very much for your participation. Hackmed is honored to have you guys here. It was so much information that I think I'll have to watch this whole session for 2 or 3 times more in order to absorb all the information. Marcia and Robson, we as Brazilians are very proud of seeing Brazilians in the top universities in the United States and doing this wonderful job. It makes us very proud, and I'm sure this is going to be a role model for people that are watching us. Thank you very much.
Leandro, was awesome, man. Thank you.
Leandro.
Nigam, great to have you. Marcia, prazer imenso te conhecer. Adorei conversar contigo. Foi muito legal.
Igualmente.
Sorry, Nigam, that needs to be in Portuguese. Okay, guys.
Bye.
Até mais. Beijo, abraço.